We are so fortunate today to have with us two health professionals who are going to speak to your questions, and the conversation is going to be moderated by a third. So let me just very briefly introduce them. Dr. Janelle White. Welcome, Dr. White is a pediatrician at Atrium Health System in Charlotte, but she's also the System Medical Director of Community Health. So besides her practice of pediatric medicine, Dr. White cares deeply about the well-being of the broader community. Thank you so much for being with us today. Dr. Amy Hinkleman comes to us from Campbell University, where she's a professor of public health, and she is a Baylor graduate and also loves to dance, but her expertise has really found her in the midst of this pandemic, working carefully with folks who are tracking the pandemic and addressing it. So our facilitator, our moderator for this part of the conversation is Dr. David Tillman, who is not a newcomer to the IFYC Faith in the Vaccine Ambassadors program. In the midst of his gargantuan set of responsibilities at Campbell, he's the director of the the department chair for the Department of Public Health there, but he's also been working deeply with his community on questions of epidemiology and contact tracing. He also led a cohort of student ambassadors in our first round of FEVA work. So thank you, Dr. Tillman, for being here to help us have a great conversation with Dr. Hinkleman and Dr. White.
Well, thank you, Dr. Henderson. I'm excited about this conversation. I'm looking forward to being a part of it and learning myself. Let me say to the ambassadors as we get started, this is your moment. I'm so glad that you're here. I'm so glad that you're participating in this. Being a mentor to a student group, I can tell you, it's a time to recognize that we are living history. A couple of years ago, when all of this started happening, we know how our lives have changed. We knew something was happening, but none of us knew how big it was going to be and how transformational it was going to be to our entire society. And I'm telling you, students, as you're embarking on this work, you're participating in a project that you're going to talk about 50 years from now, when people are saying, what did you do during the great pandemic that was happening when you were in college? And you're going to say, I was a part of trying to get the word out into the community, to listen to what people's concerns and try to be a voice of reason and assistance to them. And so what you're doing today is just a small step in what is going to be a really neat story that you're writing over the next few months. This conversation is going to focus on your questions. So we know that there's some pressure getting into work like this because our world has never been more divided, it feels like, about something that's so crucially important. And so wading into this as a student, you may wonder, like, do I even have enough information to try to be an ambassador for this? Well, the training that you'll get and the work that you'll do together as a group will help you feel confident in being able to fill the role that we're asking you to fill. And part of it's going to be hearing from these real life experts that I'm going to get a chance to ask questions to here in a second. My colleague, Dr. Hinkleman, is a professor of immunology. She spent her entire career trying to understand the science behind how human beings respond to disease and how we can protect ourselves from it. And then Dr. White is a clinician that's in one of our largest healthcare systems, leading the way and thinking about how populations respond in this moment and in moments like it. So we're going to hear from some real experts to give you information to answer your questions so that you feel more confident moving forward. So without further ado, let's jump into this and let's get started with one of the dicier questions. So Dr. White, Dr. Hinkleman, as you're getting ready to unmute for the first time, Dr. White, I'm going to throw this to you to start. The J&J vaccine, the Johnson & Johnson, when the vaccines were rolled out, there ended up being 3 vaccines. For those of us who have been working on vaccine hesitancy and trying to increase comfort levels in the community, confidence in the vaccine took a hit over time with the J&J vaccine because there were a lot of stories that came out. So can you tell us a little bit about what you tell your patients, what you do with your clinical teams around the J&J vaccine? And is that a case study in the fact that these vaccines shouldn't be trusted? What do you tell folks?
Well, thank you for the question. And again, I would just like to thank you all for the opportunity to be here and our wonderful ambassadors who are taking their time to help our communities and colleagues, friends, family members, just help them work through their questions around the vaccine. So when I have questions about the Johnson & Johnson, my answer is with Johnson & Johnson, with Pfizer and Moderna, is that all the vaccines, were rigorously tested and have found to be safe and effective. And with the Johnson & Johnson, it did have a lower efficacy. However, it has still been shown to be proven effective against severe illness, hospitalization, and death from COVID. So, the fact that, when we found the side effects of the blood clots with the Johnson & Johnson vaccine, for me, that provided assurance that this is a continuously, rigorously monitored process. So, for me, that showed that a vaccine just isn't given, to the public, and then we're just sort of step back and say, okay, here you go. For me, and I hope that provided some reassurance that despite it being administered, the same level of rigor of monitoring the side effects of it, was still in place after it was administered. And thankfully, what we saw is the risk of side effects was very, very rare. So again, we did have those side effects. And again, nothing is without risk, nothing is without side effects, no medication, vaccine, or anything that we do. But again, it is thankful that it was found to be very rare. So, I think that is one way that I try to frame that conversation, is to, at least point out that, that did show us that this is continuously monitored for safety and efficacy.
That's so interesting. So some of the things that we might have heard or read about with the J&J vaccine and some of its side effects, you're actually saying from your perspective as a clinician, that's actually evidence that that the system's working the right way, because the fact that we found those things so quickly, even though they were so rare, is evidence that that everything about the vaccine is continuously watched. Is that right? Is that what you're saying?
Absolutely.
Am I understanding that correctly?
Absolutely. No,
Okay.
that's spot on. That's spot on. That's sort of the message I would like to convey. And again, with the Johnson & Johnson, we want you to be vaccinated. So there are situations where the Johnson & Johnson vaccine is recommended for different reasons. There may be individuals who may have severe reactions or contraindications to receiving an mRNA-based product, which is really more the exception than the rule, honestly. There are situations where, due to limited access to vaccines, an individual may remain unvaccinated. So if your Johnson & Johnson is your only choice, we still recommend that you get your Johnson & Johnson vaccine. So again, it has had the lower efficacy, but in terms, again, of safety, all of the products have been rigorously and continue to be rigorously tested for safety and effectiveness.
Thank you, Dr. White. Dr. Hinkleman, as just sort of continuing in that same vein, as we look at the vaccines and how quickly they went from not being something to being available, does that give you pause, or why should the public, the folks that we might be reaching out to in communities who might be saying, I don't know, it makes me nervous that these things were developed so fast? Where do you get your confidence in the vaccines?
That's a great question. And I think it's really important to ask these questions and be open about them. Of course, these are before I got my vaccine, I went and asked these questions too, some of the things that y'all are asking. So one thing I will say is that we had just scientists all over the world that have been researching for decades these kinds of technologies. So the vector vaccine, which is the J&J, it has even longer research for many, many, many years. The messenger RNA vaccines have been undergoing research well before this pandemic started. So we had a lot of base knowledge about these vaccines. In fact, they had already been used in human clinical trials for things like influenza, Zika, rabies, Ebola. It was actually used in for some of the more recent Ebola outbreaks. So we have that knowledge base of the technology, plus we have experience with MERS and SARS-CoV-1, the original, from many years ago as well. So we actually knew a lot about this virus. So between that knowledge about the virus and then the knowledge about the vaccine, development and technology, we combine those and we're able to do something. I also just want to point out that every year, well before the pandemic, we survey the circulating influenza strains, which is a virus, also respiratory infection, also can cause severe disease and death. And that's why we vaccinate. But guess what? We make a vaccine, actually several different types of vaccines against flu every year against 3 to 4 different types of strains. So we definitely have the capability to do this. And I think one of the things about the speed is, this is the kind of thing that gives me a lot of hope and I find so encouraging, because I think sometimes it's easy to get lost in all the bad about the pandemic, but the whole world was working on this. There was this huge global effort, y'all, and it was incredible. And sharing of information, all scientific articles were freely available. If it's COVID-19, it's accessible, and that's unique. That's been a unique thing. So all over the world, we have people working on this, sharing information across countries, and you have this incredible prioritization of pharmaceutical companies, of the government to be like, okay, we were working on this, but this is, so this is our major important emergency thing to work on. So shuttling all those resources on one focused goal. It's amazing. It's a really good lesson on what we can do as a global community when we really put together our efforts. So all of those things definitely helped with the fast tracking. Here in the US, funding wasn't an issue. Usually that takes, being in research, funding can always be a big issue. So that was kind of taken off the table. You got the money, then you can go. The other thing is, as far as the approval system, all the clinical trials still had to go through the same rigor. They still had to pass phase 1, phase 2, and phase 3. The thing that we tried to shortcut a little bit is having them overlap some of the phases overlapped, but they still had to pass each one. The other thing is, there's a lot of paperwork. Believe me, in research and development, there's tons and tons of paperwork. And a lot of times you'll sit and submit something and wait 6 months to hear back when you submit a document. So that's the part that they shortcutted. They were like, this is our priority. This is an emergency. As soon as we have all that data and information to scrutinize, and then it goes through panels of experts that included people from all different backgrounds, then that was when it was going through that process. So it was really cutting down that red tape, that paperwork, all of those things to get it out faster.
That's really helpful. And so thank you. And make sure that I've got this right. I mean, Clay mentioned in the chat, I'm going to try my best to watch the chat as I'm listening to these compelling speakers at the same time. But Clay mentioned in the chat that the speed of development is one of the key concerns as you're out in the community talking to folks, and one of the key reasons that people provide about, not being sure about these vaccines. And so Dr. Hinkleman's response sort of gives us a couple of things to remember about this. First of all, it didn't come out of nowhere. It came out of years and decades of research that all added up to being ready at this moment to do this amazing thing. 2, it's not that unlike what we do routinely to produce the annual flu vaccine, where we've got to sort of forecast which flu strains are going to be relevant, and then create in a year a vaccine that's going to be the right one for that year. And then 3, we've never really lived this moment before, where blank checks were written by lots of entities saying, let's solve this problem together as a world. And what you got was some pretty amazing stuff that is the culmination of all of these systems we built over time, and with experiences with previous outbreaks that weren't quite as big as this, but still substantial. Thank you so much for contributing the science behind that, to add to what Dr. White was saying about how she's able to talk to patients and colleagues within her system. Let's talk a little bit about something that's come up already in the chat with boosters. So, one of the questions we might ask Dr. White is, if these vaccines are so good, why in such a short amount of time have I got to get another shot? Seems like I just got 2. Now you want me to get a 3rd. What's going on here? So can you talk to us a little bit about, what your telling patients and your community members as you're talking to folks about this need for a booster, where it comes from? I'm sure Dr. Hinkleman will chime in as well with the science behind that. But Dr. White, why don't we start with you and what you're telling folks when they say, why do I need a booster now?
Absolutely. So, and some of that will tie into what Dr. Hinkleman just shared with us regarding, the flu vaccine booster. So, although COVID vaccines remain effective in preventing disease, data suggests that their effectiveness in preventing infection or severe illness wanes over time. That's what we've seen. And what we saw with the Delta surge was sort of like a spike in the number of infections, maybe approximately 6 months or so after that initial wave. And that's, about the time that immunity tends to wane or decline. So hence, the recommendation for the time frame around the booster. So again, to answer the question about boosters, the virus is doing what viruses do. They, in order to survive, they mutate and they produce variants. So again, these last 2 rounds, have really taken advantage of our younger people, who did not take the opportunity to get vaccinated earlier, or may have been ineligible for vaccine. So again, I'm a pediatrician, and this wave, we have really seen, our children, the numbers of positive children spike as a result. So again, with boosters, it is not a foreign concept. Again, flu vaccine boosters are given every season, and they're, unrelated to pandemics and epidemics, but there are several other diseases where we immunize against that require boosters. Your tetanus, booster, we have to get that once every 10 years. So again, it's just one of those things. The question I get asked a lot is, am I going to have to get a COVID booster, every year, every 6 months? So honestly, we just don't know. We don't have that concrete answer. This is still an evolving situation. We're learning more, obviously day by day as time goes along. But again, we do know that naturally the protection or the immunity wanes after a period of time. So it is likely that we will need boosters, but exactly what that will look like, how often, we don't have those concrete answers right now. But just keep in mind, boosters are not a foreign concept, and again, there are other illnesses in which we protect against that do require boosters.
Yeah, that's a great reminder. So, in just your clinical practice, you encounter lots of things, especially as a pediatrician, a whole series of vaccines, some of which you get one and you're good for life, and then other ones that you need to have in certain intervals and have on a regular basis. And so different types of boosters are pretty normal, then, you're saying, in terms of our using vaccines to try to protect us from disease. Is that right?
Correct.
Okay, good. And Dr. Hinkleman, can you talk a little bit about the science of, without getting too far down in the rabbit hole?
Which I love to do.
But talk to us a little bit about why it is that these boosts might be needed. And if you could use that maybe as a segue to talk about this issue of viruses doing what viruses do and innovating and creating these variants. So maybe you can talk about all of that.
Okay. Yes, of course. So I think going off of what Dr. White was saying, I think the example of her saying the tetanus shot, right, is every 10 years. You have other boosters that are different time frames. So I think the first thing you have to understand is not all viruses are the same, and not all vaccines are the same. And some you do have to, just because of the immune response to it. In fact, even our own natural immune response to certain viruses can be different. There's some things like chickenpox, mumps, we elicit great, strong immunity. There are other things we never develop really good long-term memory, and we get reinfected. What we're seeing with SARS-CoV-2 is that even those that get COVID-19 but haven't been vaccinated, they're actually 5 times more likely to get reinfected. So you have to kind of take each virus as it is. So that's the first thing I would say. So the pathogens vary. So with this booster, it's kind of an ongoing, we're looking, we're analyzing, we're watching the data. The data was suggesting that, yes, antibody titers, which is something that helps protect you, were declining, and that's why they kind of reintroduced them. And so with the fact of why we may need them, One, it's because of immunity. Think of it as soldiers, right? Soldiers protecting you against the pathogen. Well, you'll train up those soldiers, you'll get them all trained up, right? And do they never go back to training ever again? No, right? So the booster's kind of like that, hey, let's come back to base, let's get you trained up, let's make sure you're in physical shape, or that you still know all your skills and you practice those skills. That's kind of what a booster is for the immune system. So that's one reason it's important. But the other reason is, guess what? All these variants. And so the immune system, these vaccines were developed for the original. And it's gone under several different versions. And that just happens because viruses are not so great when they make copies of themselves and they make mistakes. Now, a lot of times those mistakes are not so great for the virus, but all it needs is one good mistake, like what we saw with Delta and Omicron. Oh, I can spread faster. Guess what? That particular variant is going to be propagated more in the population over time, which is exactly what we have seen. The other thing that can happen, though, is the protein, right? That spike protein, which you always see sticking out, that's kind of the target, that can change a little bit. Again, that's part of the just randomness of these viruses not being very good when they're making copies. And if it changes it a little bit, which we've also seen, the effectiveness of the vaccine can go down. And we've seen that with the various variants, alpha, beta, delta, Omicron. Still very effective, but it can decrease that. So those are the kind of two reasons.
So as we think about boosters and the science behind it, what you're really saying, if I'm understanding you correctly, is that there's this issue of the fact that our response to a vaccine within our body kind of changes over time, and our own immune response. And so you might need sort of and to use your analogy to soldiers, sort of a retraining training exercises. So within our body, and then this thing that we're trying to fight off is changing. And so we might need a booster to respond to the thing that's happening with the virus itself. Is that right?
Yeah, and with that, you actually may have to develop something. Fortunately, the vaccines that were developed have remained very effective against the variants that we have right now. If that were to change more, because your immune system is really good at recognizing differences, then a new vaccine may need to be developed, which is kind of what some of the things are doing with an Omicron and Omicron-derived variants right now.
So thank you for clarifying all that. It's helping me think about it as well, just sort of in those two big pots of reasons that you would need a booster. But it came up in the chat. It was also one of the questions I was prepared to ask you because it came in, it was sent in as a question from one of the ambassadors. Does these variants mean that the virus is getting stronger, or is it getting weaker? I mean, with Delta, I think there was a sense of like, oh my goodness, this thing is mutating, is becoming like a super virus, right? And then with Omicron, I've heard the opposite out in the community, like, oh, well, it seems like this thing is varying in a way that's a little bit easier to deal with. What would you say, Dr. Hinkleman? What direction are we going in? Is that how it works?
I think it depends on what you're talking about as stronger or weaker, right? I don't think that's an accurate judgment of the virus. I think viruses mutate to evade the immune response. They mutate randomly, but they get selected because they are evading the immune response, or they're reproducing faster, right? Or they become more contagious, something along those lines. Those are all mutations that if it arises and it is advantageous, that particular virus is going to get selected. Now, whether or not you can call that stronger, if it can spread faster, I don't know if that's, I would just say, hey, Delta spread faster than all the other ones. Then we thought Delta was, a rock star in the virus world, and then Omicron came around and blew it out of the water. So as far as spreading faster, yes, but as far as stronger or weaker, I wouldn't necessarily say that's an appropriate term. Now, virulence, so how bad is the disease that it causes, that's a whole entirely separate issue. And that again is random, but its virulence may not be connected with, it just developing. It's not going toward the goal of virulence. It's going toward the goal of infecting more people. And that can come with or without pathogenicity, so increased severe disease.
All right, pathogenicity, you heard it here first. All right, so thank you for helping us see those kind of aspects. Dr. White, I saw you sort of nodding along a lot. Is there something you'd like to add? You sort of looked like you wanted to get in on that.
Yeah, I certainly agree. And, this is certainly a fair question that we get. It doesn't mean if it's getting weaker or stronger. So, I 110% agree with Dr. Hinkleman that it's difficult to say that. What I would say is it's getting smarter. It's just learning how to survive. So, that is how I would probably explain it, is that it is learning how to survive and how to get around, the measures that we have put in place, and just if nothing else that we take away from today is, that we are still seeing the majority of our severe illness, hospitalizations, and deaths among our unvaccinated populations. That is one fact that has not changed, regardless of where we were with wave, Delta, Omicron, our initial wave. The fact that has remained consistent is that, we are seeing the majority of the morbidity and mortality among the unvaccinated.
I'm going to ask you just a real quick follow-up, and then I want to shift gears a little bit, Dr. White. I got COVID myself about a year ago, and I was pretty sick. And then right after I got COVID, I got my vaccine. There's a question out in the community. Well, if I've gotten COVID, why would I need to get a vaccine? I was pretty sick for my COVID, and I still went out and got a vaccine. Why would somebody make a choice to do like something like that? Doesn't the disease itself give you some protection? And now that so many people in our community have gotten Omicron, doesn't that make sort of the vaccines less important? What would you say to that?
Yeah, that's certainly one of the top questions that we get, should I still get a vaccine? So, the fact of the matter is, nothing in this life is 100%, so again, if we were to have COVID, the actual infection, yes, it does produce some antibodies, some immunity, but we're not quite sure, it's not sort of a constant level of immunity. And again, our reactions to the actual virus, the amount of immunity that we build up may vary, from person to person. So we do know that the vaccine does provide a consistent level of immunity, and we're able to measure that a bit more consistently. So again, even if you still have contracted COVID, it is still highly recommended that you get the vaccine because, again, as Dr. Hinkleman mentioned, there is a pretty good chance, higher chance of reinfection, particularly with this strain. And as I mentioned before, the one thing that has remained constant is the majority of our severe illness and unfortunately death remains among the unvaccinated. So again, there's still that great opportunity to protect yourself, even if you have been infected with the actual virus.
So, Dr. Hinkleman, thank you, Dr. White. That's very helpful. Dr. Hinkleman, I want you to start here, and then we'll segue to getting the pediatrician's standpoint on the same thing. The question that came through is, we think about the work of these ambassador teams. A lot of us, including the team that I'm heading here at Campbell, we're really focused on helping support parents and being able to answer their questions about getting their children vaccinated, which was not something we could even talk about last year at this time. Can you talk to us about how do we know that these vaccines are safe for young children? Amy, can you talk to us about how this process works for children?
Yeah, so it's very similar to the process, right, that we use for adults. And in general, because they're considered a vulnerable population, and you're always kind of looking at the risk of disease versus the medical intervention. So in this case, the vaccine. So what does that look like? And so that's why they did clinical trials, just like they did with the adults. So the process is the same. You have your 3 clinical trials, you have thousands of participants in those clinical trials. They look at everything. Any side effect from any vaccine in the past, that's flagged. Any type of adverse event is flagged during those clinical trials. And the clinical trials for the children were stellar. They were really, really encouraging. They didn't really report anything serious as far as adverse events. So it was better, actually, I think, looking at the clinical trial data, at least, was actually better than even the adults.
Which was also stellar, right?
Which was also stellar. Yeah, I do want to just point out that we have, what is it, billions of people on the globe. And then here in the US, I think we're up to like 500 million doses or something, and over 200 million people vaccinated. I just want to sink that in, because that's a lot of people. That's a lot of, as far as a scientist, we call them N values. That's a lot of people and a lot of surveillance. As Dr. White mentioned earlier, after the clinical trials, there's still several mechanisms for intense scrutiny. So we have probably, if you think about it, the quickest and largest distribution of any type of medical invention ever, are not just across the United States, but across the globe, and the most scrutiny that any type of medical intervention has ever gone through. And we're really still not seeing a lot. I mean, that gives me my nerdy goosebumps, is what I call them. That is really incredible. So what are some of these other surveillance systems that we have in place? Well, there's follow-up right after the clinical trials. There's at least 6 months of follow-up. There's the VAERS system, if y'all have heard that, the Vaccine Adverse Event Reporting System. I always have to think about that acronym, where any person, right? So healthcare providers, non-healthcare providers, anyone can report any event to that system. And then scientists will kind of look at those events and compare them to the general population. So like, say you developed a rash a week after getting the vaccine. Well, they'll look at all the people that developed rashes versus the general incidence in the population to see, is there an increased risk? And that's actually how we've identified things in the past that are extremely rare. That's how we identified some of these very, very rare events, because when you're talking about an event that happens 1 out of several million, you wouldn't, in the clinic, Dr. White, you probably wouldn't notice that, right? So you have to have all that information coming in. So really, really high level. There's also collaborations with the CDC and multiple healthcare institutions where it's called Data Link program. They're looking at patient records, and there's a computer system that is much more powerful than our human brains to pull out those rare events, since they are really difficult to see. So all of those things should give you encouragement. And kind of what we saw with J&J.
You're saying tens of thousands of actual human kids were a part of these clinical trials. And then since that time, you're talking about millions of kids who have received vaccine. And all the while, there's been intense scrutiny to make sure that these things are safe, and that if there were any sort of side effects happening, we are detecting even the smallest little blip using these huge data systems and artificial intelligence even.
Yeah, so usually clinical trials about a few thousand, and then yes, there have been millions of children at this point that have been vaccinated, and that age range from 5 to 11, and then above that even more.
Thank you. So that gives us a lot of actual facts to know, okay, did we just decide, the kids should probably have some too, we'll give them half as much. That's not at all the process that leads us to this point. But that's the science. So Dr. White, when you're actually, working with families and you're having to make these decisions, and we know that some families are, I think in the chat it was mentioned that some families are hesitant even with flu shots, and certainly other vaccines. We know that many years ago, there were all these rumors about vaccines and that kind of thing. And we see that intensified in this particular moment. So how do you talk about kids and the vaccine for kids with parents?
Well, what I have encountered quite often is, the question for me is, from my understanding of what's been reported, that children are less likely to develop serious complications. So I can only report what I hear on the ground, and I'm just not sure. I just, always say this one that I want to be very careful of, because I'm not quite sure we can state that as a fact. We don't know the long-lasting impacts of this virus, not just physically, but mentally, and the social well-being of this generation of our children and youth. So, again, this infection is not always without consequences, and similar to adults, there are some children who may have mild illness, while others may end up hospitalized or even worse in the intensive care unit or ventilator. So again, it's sort of the same in adults. They contracted COVID, they had, maybe what they would deem mild symptoms, and did fine even they were unvaccinated. And then there were others who we unfortunately have lost. So, again, we've seen consistently, in addition with the adult populations, that the majority of children who are hospitalized with COVID are not vaccinated, and again, some of that maybe did not get the vaccine, or again, they're just not eligible to receive it because of their age. The other complicating factor with children is that they have the risk of developing MIS-C, multi-inflammatory syndrome of children, which is thankfully a rare, but it's still not a very well understood condition. But we do know that that condition causes the immune system to overreact to COVID. So it leads to inflammation of the organs, including the brain, the heart, the lungs, and the kidneys. And with that, the MIS-C typically occurs weeks after COVID-19. So, with this strain, this most recent surge that we've seen, sometimes we do know that the hospitalizations in children can lag. So, it may lag a couple of weeks after the adult. So we may not see the entire picture just yet. And then again, what the long-term effects are on our children and youth, we just don't have that information, nothing that's concrete. So that's why, we just try not to overgeneralize and say, well, the children are probably not going to develop serious complications, because we just don't know that. I have personally seen patients with what's called the long COVID symptoms, persistent loss of taste and smell, persistent headache, persistent fatigue. I have not personally encountered that with any child who's received a vaccine, so again, we just sort of have to look at it, on both ways.
I mean, that's a really interesting point. Before I'll let that go, and there's some discussion on the chat about this notion that, especially early on, there were a lot of reports out about the number of unvaccinated that were filling up the ICUs and that kind of thing. And one of the questions was, it seems like I haven't heard as much about that. I know I happened to see Atrium's data from, I think, this past week. You're still at 91%, I believe, of the ICU space that's being occupied because of severe COVID illness. 91% is still unvaccinated. And you're seeing that true through to children. That's with adults and children, that these severe complications are happening overwhelmingly in the unvaccinated. Is that correct?
Yes.
Okay. Yeah.
That's the thing that I've said consistently. That fact has not changed. We've had many variables through this, but that has been the one thing that has remained consistent throughout this entire pandemic.
And Corey, Corey, just in response to your question, I think one of the things that might happen in media is just they can't keep telling the same story over and over. And so media might not be able to grab headlines by reporting this over and over, but most hospital systems are putting the information up week to week, and it's just not changing. So it's not a great headline, but it's important for us to remember as ambassadors. The last thing I want to talk about came up lots of times when I would be in the community working, and it came up as a question. I oftentimes see students sort of connecting to younger families and younger adults in their work in the community. It certainly comes up for this demographic, and it's, what is the relationship between vaccines and fertility? So as people are thinking about family planning, and people may be pregnant, and people may want to become pregnant, should there be a hesitancy around that? Dr. Hinkleman, do you want to start with sort of the science of what we would know might connect to vaccines and fertility, or not?
Yeah, there's no data, this vaccine or any vaccines, about any impacts to fertility. Male or female fertility. And the science behind it and the mechanism of how these vaccines work just frankly doesn't make any sense for that it would possibly even have. It doesn't seem even plausible. So the fact that we have, again, been tracking things so well, and that there's no data to support this, and the history of vaccines don't support this either. I think that gives you a lot of confidence in that. The other thing is that people who there are accidental pregnancies in the clinical trials. There's been pregnancies all throughout. I mean, think of, 500 million people just here who have gotten a dose. That's a lot of people who were planning to get pregnant, weren't planning to get pregnant, but got pregnant. And comparing, again, using those systems of miscarriages and differences between populations who got vaccinated or didn't get the vaccine, there hasn't been any difference as far as those types of things. So I know I kind of got in a little bit of pregnancy, but I think it's also important to point out the risk to pregnant women with COVID-19 is extremely higher. So it's higher across all populations, but pregnant women would be one of those higher risk populations. And I think it's an important thing while we're talking about fertility to just bring that up, that there is a much higher risk. So it's very important to actually get vaccinated.
Yeah, so there's so much that we have not seen in terms of a connection in any of the data that would cause a concern, but we have seen how impactful COVID can be on pregnancy in ways that harm mother and child. So that, thank you for reminding us of that. Dr. White, anything else that you would add to that as you think about how you counsel patients and families around the COVID-19 vaccines and fertility?
Yeah, I certainly share all of the information that Dr. Hinkleman shared, and then also what I may add is, our professional medical organizations, including the American College of Obstetricians and Gynecologists, Society for Maternal Fetal Medicine. These are the societies and organizations who serve people of reproductive age, including adolescents, and they emphasize that there's no evidence that the COVID-19 vaccination causes the loss of fertility. So, and these organizations recommend the COVID-19 vaccination for people who may consider getting pregnant in the future, and there's just no data, to support that the vaccines impact fertility for anyone who's trying to get pregnant, may become pregnant in the future, as well as their partners.
Wow. What a perfect way to respond with just both the evidence and then this vouching for their credibility through these professional organizations. Students and ambassadors, what you're doing right now, what you're doing this afternoon is, I'll be honest with you, I didn't really know that little endorsement from the professional associations that Dr. White just shared with all of us. And the reason that we're having this conversation together and you're doing these other training things is because a lot of the people that you're talking to, they're not going to know about that either. But you're going to put yourself in a position in the community to be a listening ear and to be a helpful voice where you find opportunities. And what you can share are these things that you've learned. And so what will get you an opportunity to be important to somebody in their decision making about these kind of things is the relationship that you're building and your accessibility. But then what you're able to share can come from the work that you do in these conversations, in this training, and learning from each other and asking experts continuously as you hear questions in the community so that we're giving. The hard thing right now is having clear information out there because there's so much noise. And so you can be a trusted voice, and we're trying to give you some trustworthy information to share. Help me thank our panelists as we wrap up here. Show them some love in the chat box. Give them a little silent round of applause. Dr. White, is a pleasure to get to meet you. Your voice was really helpful in this conversation. Thank you so much. Dr. Hinkleman is a good friend and colleague, and we were just so lucky to have her at Campbell. And so thank you for being a part of this conversation as well, Amy. Thanks so much.